Good morning, everybody. Today we'll go through examination of chest for PACES candidate. And also to be more concise and do our practice by subconscious mind, because chest examination is the longest examination in the exam. First of all, we have to know before enter the exam room what we will face inside. What are the common cases in the exam, in the chest examination? Common cases in exam: chronic obstructive pulmonary disease, bronchiectasis, interstitial lung diseases, pulmonary fibrosis, lobectomy, thoracotomy, pleural effusion, consolidation or collapse, and combined lesions. Combined lesions means patient came with chronic obstructive pulmonary disease associated with interstitial lung disease, or patient came with bronchiectasis associated with lobectomy or thoracotomy, or patient has consolidation associated with pleural effusions. So most of the cases in our exam, it could be combined, two pathology present in the same case. Generally, for any examination in PACES exam, you have to look for three items. General examination, it is the first item. Second item, focus examination on the requested system. Requested system mean focus in chest or heart or abdomen or neuro. Then examination to detect causes and complications. I will give an example. If you want to examine patient has chest problem, and this patient you have to examine him generally first, then focus exam in the chest, and also you can detect if this patient has cor pulmonale or not, or this patient has respiratory failure or not. You have to look for this issue during examination. It is very important after you finish your examination to make a presentation for examiner. Presentation for examiner, it should include positive sign in general examination and mention negative important signs. Here in chest you have to give me if this patient has respiratory failure or not, if this patient has cor pulmonale or not, if this patient on steroid therapy or not. So that you have to mention positive sign in general examination, you have to mention negative important signs, and positive local signs, and positive signs of complications. And mention also at the end of your exam what would you like to examine more. As in chest case, you want to do for this patient, don't do for him sputum culture and sensitivity, you want to do him pulmonary function test, or you want to do for him peak expiratory flow rate. Then mention what the possible causes of etiology. I mean that possible causes of etiology for the patient, if this patient has obstructive lung disease or this patient has interstitial lung diseases. So in your final presentation, because it will include your work with the patient, should include the positive signs and most important negative signs. In the station 1 that include abdominal case and chest case, you will sit 5 minutes outside the room, and in this 5 minutes you didn't do anything, just to waiting the bell to enter the room. So after enter your room, After entering your room, you first introduce yourself to examiner. The examiner will open the door for you and he will shake hand with you and he will introduce himself to you and his colleague. First thing, you have to request from the examiner to wash your hands because it is a good infection control before you examine the patient. Then go to introduce yourself to the patient and take a verbal permission to examine his chest. Dear sir, would you mind to examine your chest, please? And also during examination, you have to speak with the patient and tell him what are you going to do. I am going to, as example, I am going to tap in your chest. I am going to auscultate your chest. You have to, before every step, you have to tell the patient about what are you going to do or what are you doing now. Examination of the chest. As I used to inform all MRCP candidate, you have to put for yourself a pathway. And if you put a pathway for each the stations so that you can work easily without any stress in yourself. In chest cases, you have to examine 4 items: hand, face, lower limbs, and chest. And in chest, we have to make an inspection, palpation, percussion, and also auscultation. In my pathway, once you enter the room, please don't expose the chest of the patient. Go to examine the hand first, then face, then expose the chest of the patient and examine the lower limb. And during examination of the lower limb, you can look and make an inspection for the chest. General examination. First of all, ensure that the patient is sitting in 45 degree. You have to make a general survey to look around the bed. If this patient has any nebulization, oxygen cylinder, or inhaler. Maybe the patient has frequent cough or audible breathing sound. It is a clue for you. If this cough is wet cough, you can check if this patient could have bronchitis, or the patient could have also not bronchitis, maybe chronic obstructive pulmonary disease. Look for the patient body build, if the patient is cachexia or not. Cachexia means this patient had chronic disease, mostly bronchitis or lung abscess, or he has cancer. So general examination or general survey will give you a clue about what are you going to find in the local examination, so that you have to be sure the patient in 45 degree to examine his neck. You have to notice if this patient is breathless at rest or not, because breathlessness, it is one of the signs if this patient has exacerbation of his condition. Look for his lips. His lip is pursed or not, because pursed of lip indicates this patient has a small airway obstruction. And one of the golden rule in the exam, please don't touch the patient if that not necessary. Don't always all time touch the patient. Only touch the patient if that necessary to be touched. We'll go for our journey in the chest examination. When you enter the room and you shake the hand of the patient and then you make the general survey for the patient, you will start by the patient hand. Ask the patient to put his hand straight, his hand in front of him, and look for tar staining. Tar staining has different side. Usually it is between fingers, this tar staining, and look also for nails. What is the evidence of nail examination in chest case. Nail examination in chest case, we have to look for clubbing. Clubbing, one of the important sign in the chest, because it indicates this patient has toxic manifestation. I mean that this patient has suppurative lung disease, like bronchitis, or this patient has cystic fibrosis, or this patient has cancer. So clubbing is very important. Then you look for the skin, dorsum of the hand. This skin could be tight, skin as scleroderma, so that I suspect this patient could have interstitial pulmonary disease. Or thin skin, if there is thin skin, I suspect this patient in steroid therapy. After you examine the skin, look for also joint. Maybe the patient has rheumatoid arthritis. And what does that indicate? That indicated the patient has rheumatoid arthritis. Maybe she has or he has rheumatoid lung disease, like interstitial pulmonary fibrosis, or this patient has obstructive lung diseases. Then look for cyanosis, if this patient has peripheral cyanosis or not. Actually, the exam may be in the cold weather, so that maybe the patient prefers cyanosis due to cold weather. Take care of this. Then also look for tremors. Tremors here, fine tremors. What mean by fine tremor? Fine tremors, you have to look for fine tremors that indicate maybe this patient on drugs, and these drugs like beta-2 agonist could be the cause of fine tremors. Then also look for flapping tremors. Flapping tremors, you have to make for the patient extension at the wrist joint, and also abduction of fingers to look for any flapping tremor, and that indicate the patient has respiratory failure. Then look for palmar erythema. It is very important to look for palmar erythema. So in the hand of the patient, you look for clubbing, for skin, for any manifestation of rheumatological lung disease in the hand, and also you have to look for cyanosis and look for tremors. This tremor could be fine tremors, or the tremor could be flapping tremors. Then check pulse, and pulse, it will give you a value. What is the value of pulse? It will give you pounding pulse most common in the patient has CO2 retention, or this patient has multiple extrasystoles or supraventricular tachycardia if the patient has COPD exacerbation. During counting of pulse for 15 seconds and still your hand on pulse, take another 15 seconds to examine the respiratory rate. That is very important to examine respiratory rate while you are putting your hand on the pulse, to give the attention of the patient to be away and this patient not concentrate with you. After finish pulse, please check muscle weakness. What is the evidence of proximal muscle weakness? You have to tell the patient to make your hand like this, just abduction of the shoulder, and check the power of the abduction. Why? Maybe this patient in steroid therapy and he has muscle weakness as a complication of treatment. Also, during examining the hand, please look for any wasting of the finger. What that indicate? Maybe indicates this patient has lesion in thoracic 1 or pressure due to Pectus tumor. So, general examination until now will give you a lot of clues. If you found in one of these clues, it will give you a data before you examine the patient's chest for local examination. Now you look for hand for what? Nails and the skin and the joints of the hand for tremors and look for pulse and respiratory rate, muscle weakness, and any manifestation of collagen disorder. Please again don't forget to check if there is any muscle weakness or not, because this patient on steroid. This is clubbing. You have to check with the patient clubbing by making for him do your hand like that and check if there's any window or not. This is cyanosis, peripheral cyanosis. We have to check for peripheral cyanosis, but take care maybe in cold weather. After you make general survey and you examine the hand and examine pulse, respiratory rate, and you checked already muscle weakness, we'll complete our journey to check the face of the patient and the neck. After you finish examination of any muscle weakness in the shoulder abduction, you have to check for neck vein, if it is congested or not. Congested neck vein in the chest case, you give you a value. This patient could have right side heart failure as a complication of chronic obstructive lung disease. After you check the neck vein, you will go to eyes. In the eye, you have to look for pallor. After taking permission for the patient, please, I will press here to look. Please look up to check if there is pallor. At the same time, look for jaundice. And jaundice in the patient in chest case, it could include what? What is the clue for what? It could be a clue for right side heart failure, or also could be a clue, could be malignancy, and also could be a clue for alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin could cause cirrhosis and at the same time could cause emphysema. Then I will look inside the eye for redness of the eye. So in the eye, you have to look for 3 colors. Number 1, pale for pallor, white for pallor, yellow for jaundice, and red eye. What is the evidence of red eye? Red eye in chest case, it indicates this patient has congestion, maybe TSO2 narcosis, CO2 retention, congestion of the eye, and could cause also papillary edema. I am still examining the face. I will check if any cushionic face. This indicates this patient on steroid therapy. Polycythemia, it is a complication of hypoxia for the patient, could cause secondary polycythemia. Now after finish the face, I will look for tongue. What is the evidence in the tongue? I will tell the patient to raise his tongue up and look inside the tongue if this patient has center cyanosis or not. It is very difficult to check it, but if you found lupus pernio, so that the patient has sarcoidosis and complicated by interstitial lung disease. So in the face and the neck, first I will check jugular venous pressure of congested or not. I will look for pallor, jaundice, and redness and polycythemia. I will look for the face for cushionic face. It could be this cushionic face manifested related to the drug, and also look for center cyanosis in the tongue and lupus pernio in the face. Till now, you didn't expose the patient. The patient is still not exposed yet, so that till now you maintained the patient welfare, and so that it is a good to avoid unnecessary exposure of the patient. Now ask the patient to expose his chest and go to the end of the bed and check if there is lower limb edema. After ask the patient, do you have any pain in your legs here? No? Check the lower limb edema. If you found there is edema by inspection, you can put your hand just below the medial malleolus, because it is the dependent part of the leg and easily to found edema. When you press in the lower limb, please look for the patient face. If maybe the patient has pain and he didn't express for you this pain. So you have to maintain the patient welfare all time. Just practice breath to check if there is any pain, and after that check with your hands to find if any pitting edema or not. Now you will go to start to examine the chest locally, and our journey will go first by inspection. The most important clues in the chest examination is inspection. If you inspect well, you could find the final diagnosis without put your stethoscope to auscultate the patient. Now we have two pathways. One of the candidate prefer to examine the chest from the back first, and other candidate want to examine the chest from front first. So examination of the chest from the back, it will give you clue. You will examine trachea at the start, and trachea could, if deviated to one of side, it is a clue. And other prefer to examine the chest from front, and myself also I prefer to examine the chest from front. This is the chest topography. The chest we have two lines, middle and left midclavicular lines, and there's mediastinal line. And in the axilla we have anterior axillary line, posterior axillary line, and mid axillary line. In inspection, I am still now at the end of the bed. Beside the legs of the patient, I will look for shape of the chest and size of the chest, deformity, any scars, and I will ask the patient to take deep breath, please, and I will check if during upward and downward movement of the chest I may be found this patient has area of not movement like other area, maybe fibrosis or collapse or pneumonectomy, or this patient has pneumothorax or pleural effusion. I will look for the intercostal muscle. If action of accessory intercostal muscle, it will indicate this patient has respiratory distress. Please, when you inspect the chest, go and look for both axilla. Don't forget to inspect axilla, as may be any scar of lipectomy or pneumonectomy present in the axilla. Axilla, it is apart from chest examination. So inspection should check the size and deformity, any scars and any symmetrical movement and any restriction of the movement. It is an example of deformity. This is Pectus excavatum. Now after inspection I will go to palpation. Palpation, you have, as we agree at the start, I have to tell the patient I am going to palpate your chest. If you have any tender points in your chest, before I examine, I have to ask the patient about that. Then I will examine chest expansion at supramammary and mammary and inframammary areas, and check if there is any restriction or any limitation of the chest expansion at both sides or one side. It will give you a clue. If you put your hand and there is symmetrical decrease in expansion of the chest, you are dealing with obstructive lung disease or pulmonary fibrosis, and diffuse pulmonary fibrosis. If only one side has been limited, that indicate the lesion in this side could be fibrosis, could be collapse, and also could be any lesion inside this patient who has lipectomy or pneumonectomy. Tactile focal fremitus by palpation, it is replaced by tactile focal resonance, so no need to do it. By palpation, please don't forget to examine the base apex heartbeat. Apex heartbeat, it is very important to examine it in the chest case. Why? Maybe you didn't find the apex at the left side and you found it at the right side. It indicates this patient has Cartagena syndrome. or maybe this patient has dextrocardia. So it is very important to check if this patient has any apex at the left side or the right side. Also, maybe the apex in the left side but inside the mid-clavicular line, left mid-clavicular line. It indicates maybe fibrosis or collapse, or this patient has pneumonectomy. So in palpation you have to palpate chest expansion and palpate also apex of the heart. No need to do tactile focal parameters by palpation because it replaced by tactile focal resonance. For percussion, you will start percussion, so I will tell our patient we are going to tap in your chest, please. In percussion, we have to do right and left side at the same level to compare between it. To be sure that to give a proper percussion, your finger should be in the intercostal space, and remember first to check the upper level of lever. Before start to percuss the chest, please check the upper border of lever. Why? If the upper border of lever is below 6 rib or 5 intercostal space in mid-clavicular line, it indicates maybe this patient has emphysema. And you have to percuss first from upward to downward, including the supraclavicular area and the direct percussion on clavicle. Start by supraclavicular area and compare right side and left side. Then direct percussion of the clavicle in the middle part of the clavicle, not on the outer part, because in the middle part of the clavicle there is no muscle. In the lateral part of clavicle there is muscle and maybe give you a wrong sensation. The patient has dullness. In your percussion you have to do in S-shaped. What mean by S-shaped? Percuss on the right, then left, then left, then right, then right, then left. This is the percussion. So in percussion we have to do upper border of the lever, start by supraclavicular area and percuss direct in the middle third of clavicle. Please again don't forget axilla. As we told you to examine the axilla in inspection, you have to examine it also in the percussion. In percussion, you could find there is normal lung, resonant or hyper-resonant lung, or dullness or stony dullness. Everyone has a differential diagnosis for your finding. Auscultation. In auscultation, you have to do the same way like percussion. I mean, you have to do in S shape. Auscultate one area in the chest, right side, the same area in the left side, and another area in the left, then another area in the right. Auscultation you have to do for 4 levels in the anterior chest wall, like percussion also 3 to 4 levels in the anterior chest wall. What are you going to listen in auscultation? For auscultation, you have to tell me what is the type of breathing. It is normal, or it is vesicular breathing, or it is vesicular breathing with prolonged expiration, or it is bronchial breathing. So you have to give me a comment on the type of breathing. Also, you have to give me a comment on air entry. Air entry, it is normal or reduced or absent air entry. And everyone has a pathological definition. Number 1, give me what is the type of breathing. Number 2, what is the air entry. And number 3, additional sound. Are you hear any additional sound like pleural rap, or you heard wheeze, or you heard also, or you heard wheeze, or you heard crackles? After you make auscultation and give me 3 items of like that, please also make focal resonance. Just tell your patient to say 99 and if you found that 99 or 44 all over level, please again don't forget to auscultate axilla. Whispering, do it if you found there's bronchial breathing. So the item of auscultation is type of breathing and if air enter diminished or not, additional sound like wheeze or crackles or pleural rub, do focal resonant and whispering. Air entry could be normal, diminished or absent. Breath sound could be normal breath sound. Could be normal breath sound with prolonged expiration, could be bronchial breathing. You have bronchial breathing, we hear it usually in 3C. Consolidation, collapse with patent bronchus or cavity. And so that if we found bronchial breathing, we have to do whispering. If we found by auscultation there is rhonchi, it is indicate there is airway obstruction. Pleural rub, it could be heard. Crackles, if we have crackles, we have to comment about the size, time, and the relation to cough. It is early inspiratory crackles, like chronic bronchitis, or mid-inspiratory crackles, like bronchiectasis, or late inspiratory crackles, like interstitial lung diseases. If we found the crackles, I have to estimate what is fine or coarse crackles, end inspiratory or early inspiratory, and the relation to cough. I have to ask the patient to cough. If the patient coughed and the crackle disappears, that is mean secretion. If the patient is cough and this altered in the crackles, it is bronchiectasis. If it is fixed crackles, that is mean fibrosis. So in crackle we have to comment size, time, and the relation to cough. Maybe in the back, when I examine the back, I will tell you to let the patient bending forward also. If crackles decreased, it means that maybe interstitial lung diseases. Ask your patient to say 99 each time for focal resonance. If focal resonance is increased, examine for whispering by asking the patient to whispering by 99. Determine of the sound could be assess egophony, which may occur with bronchial breathing or cavities. So we finished examination now at the front. I will let my patient to sit and examine the back. Once the patient sit, before examining the back, I have to examine trachea and lymph node for the patient. Start by examining the back by telling the patient, could I examine your back? I will examine trachea. Trachea I will examine for what? First, it is central or not central. And it could be tracheal tug and cricosternal notch distant and fixed expiratory sound. So in the neck, I have to examine if there is any tracheal tug or not. It is painful, maybe no need to do it in PACES exam. I will check cricosternal notch distance. If more than 3, if less normal 3 or more than 3 finger. If less than 3 finger, it is indicate obstructive lung disease. I will check the trachea position. So that trachea position could be deviated to the right or left. Minimally deviated to right, it is normal because continuity of the right bronchus with the main trachea. And after that, I will check the fixed expiratory sound. Why fixed expiratory sound? Fixed expiratory sound, we do it by putting the stethoscope on the trachea and tell the patient to take deep breaths and then to make forced expiration, and the time should be less than 6 seconds. If more than 60 seconds indicates this patient has obstructive lung disease. So when the examiner asked you what is the evidence of obstructive lung disease in the neck, you have to tell him there is decreased in the cricosternal notch, tracheal tug, and increased forced expiratory time. Then examine the lymph node. Lymph node examination, when you behind the back of the patient, check for submental, submandibular, and anterior cervical lymph node group and at the anterior border of sternomastoid, and I will check also pre-auricular lymph node. Then from the front, I will check from the front. I will be in front of the patient. I will check posterior auricular lymph node and posterior cervical lymph node and also supraclavicular lymph node. Some doctor postpone supraclavicular area for percussion and auscultation when he examines the back. This is the distribution of the lymph node. Then I will inspect the back for any scars, present any deformity like scoliosis or kyphosis. Then palpate and I will check chest expansion, and don't make your hand too tight as may give you false result of examination. I will percuss the back. I just tell the patient bending forward. It may help to cross his arms in front of the patient to pull the scapula further apart, and will percuss on the back in the superior to the scapula and also inferior to the scapula. After finish the percussion, I will auscultate the back at the same area of auscultation of percussion of the back, and I will check if this patient has any sacral edema or not. Very important to check sacral edema. Now you finished your examination. So in summary, examination of the chest, it will include number one, hand, so that for arms for pulse, hand for knees, for skins, for pulmonary erythema, for tremor, forearm for pulse and respiratory rate at the same time, and also and for arms arm for any muscle weakness that indicates the patient in steroid therapy. Then I will check neck vein. Then I will look for the face. I will look for any cushinate appearance. I will look for eye. I have 3 colors in eye. These 3 colors will be pallor for jaundice and congestion. Then I will look for any lupus pernio to indicate the cirrhosis. I will look for central cyanosis and in the tongue. Then I will go back to examine the lower limb for lower limb edema and make an inspection to the front. From the down, I will inspect scars or deformity and chest asymmetry and chest expansion. Then I will inspect axilla from beside the patient. Then after that, I will make an palpation to the patient. I will make chest expansion, and please don't forget to examine the apex of the heart. Okay, then percussion, I will percuss the supraclavicular area and in the middle third of the clavicle by direct percussion, and I will percuss in S-shaped of the heart, and also I will percuss the upper border of liver. Please, again, don't forget to percuss the upper border of liver. So don't forget to check apex of the heart. Don't forget to percuss our border of the liver. Don't forget to inspect the axilla. Don't forget to palpate percussion of the axilla, and don't forget to auscultate the axilla. After that, you have to make a percussion in the same area, make auscultation, it is in S shape, and after that you have to tell the patient to sit and examine his neck for tracheal tug and centralization of trachea and cricosternal notch and forced expiratory sound. Then examine your lymph node. Then go to the back for inspection. Please, in the back, don't forget to comment if the spinal cord has any kyphosis or kyphoscoliosis, and then palpate the back, then percuss of the back, then auscultate the back, and please don't forget to do to check sacral edema. Now you finished your examination. After finish examination, please don't forget to cover the patient after finished examination and thank him. Then turn to examiner and inform him about your presentation and tell him after finishing presentation, I would like to finish my examination by examining lymph node if you don't have the time to examine lymph node, to check vital chart and sputum analysis, and do for the patient pulmonary function test. During presentation to examiner, please don't look for the patient again. The patient will not say any words for you. Just give your back to the patient and your face to examiner, and concentrate well in the examiner and make eye contact and be confident during your presentation, because it is the first impression with the examiner, and first impression, it will a last impression for them. So you have to present yourself with positive sign. As I mentioned for you, present positive data, mention important negative data, try to mention if you have any complication from the disease or the patient on drug. In patient in chest case, please don't forget 4 things. Don't forget to tell the examiner this patient has star staining or not. Don't forget to give the examiner if this patient has respiratory failure or not. Don't forget to tell the examiner during the presentation if this patient has evidence of cor pulmonale or not. And last thing, and very important, to tell the examiner this patient has steroid therapy or not. It is 4 important things. If you mentioned it to the examiner, really you will impress your examiner. The examiner will ask you, have you finished your examinations? You can tell him, I would like to examine lymph nodes. If you didn't examine, I will look to check vital chart, and I will have to do sputum analysis and pulmonary function test. The next question will be, what are your positive findings, or could you present your case? Don't imagine the examiner will ask you a difficult questions. Really, it is very simple questions, but it is a hard time for you. You have to full concentrated in the questions. The examiner will ask you maybe 3 to 4 questions. You know well what is this questions. He has to ask you what your positive finding. And the next questions, what is your diagnosis? And the third question, what is the investigation you would like to do for the gentleman? And if maybe he will ask you, could you tell me what is the single investigation for this man, or what is the complication could be happening for this man, or is this patient to complain from what you suspect? This is the chest examination in a brief. I hope that this chest examination will help our candidate to get through the PACES exam soon. Finally, I will thank you for all candidates to be patient to listen for this short brief talk about chest examination, and follow up with me in our page Guidance to Pass PACES, that we give you a lot of videos about PACES exam, either this video related to clinical situations or related to history and communications and station 5. Thank you for all, and see you soon.